failure is a chronic, progressive condition in which the heart muscle is unable to pump enough blood to meet the body's needs for blood and oxygen. This condition currently affects 6.5 million adults in the United States, and its prevalence is projected to increase by 25% by 2030. An acute exacerbation of chronic heart failure will typically result in an inpatient hospitalization. While a large portion of acute exacerbations can be attributed to the mismanagement of the chronic illness, annual costs for heart failure care can exceed $30 billion. Hospitalizations are responsible for the majority of this cost. It is estimated that one-third of heart failure patients who are hospitalized are readmitted within 30 days. The Center for Medicare and Medicaid Services has implemented new guidelines which deny payment for submitted charges of heart failure patients who are readmitted in a 30-day period. With these new guidelines, healthcare facilities are faced with an urgent financial need to reduce heart failure readmissions. Preventable hospital readmissions are an overwhelming cost to Medicare, accounting for $15 billion annually. Any readmission into an inpatient facility will place the health of patients in jeopardy. Hospitalizations can place patients at risk for loss of function, hospital-acquired infections, as well as other poor outcomes. One modality that is growing in use and effectiveness is telehealth. The term is just one part of e-health, or an emerging field in the intersection of the medical informatics. Public health and business that refers to health services and information being delivered or enhanced through the internet and related technologies. Telehealth provides patients with direct access to medical experts who can readily identify and treat issues before an exacerbation occurs, requiring an inpatient admission. Servant leadership can be one administrative theory applied to aid in the reduction of heart failure admissions. This style of leadership was first discussed by Robert Greenleaf in 1970 in his essay which surmised that one is first a servant and then a leader. Servant leadership can be used in an organization which desires to transition from a traditional model of patient care delivery to a patient-centered model of practice. The role of the mid-level provider in the use of telehealth to address heart failure readmissions can have similar traditional roots as in nursing themselves. They share the value of taking care of others. As a management strategy, servant leadership appears to increase nurses' job satisfaction and retention, which can lead to a subsequent improvement in patient outcomes. As a patient educator, the servant leader assures that the patient is ready for the complexities of self-care. The servant leader also gives the patient a voice in structuring their healthcare plan and acknowledges the patients are unique. This type of leader adapts to the patient's individual needs and remains flexible in assisting the patient to meet outcomes. Finally, this leader is not merely responsive to the need for change, but anticipates it and prepares the patient for it as well. The patient's growth and well-being are also primary concerns of the servant leader. The practice of collaboration in servant leadership can have an impact on the mid-level provider's relationship with other healthcare professionals as well as the patient-provider relationship. Particular characteristics of the servant leader which rationalize the choice of this theory as a possible resolution for the problem of heart failure readmissions include listening, conceptualization, foresight, and commitment to the growth of people. The servant leader will use listening as well as an emphasis on the importance of communication in order to identify the willingness of the patient to perform self-care. The incorporation of telehealth or e-health into a heart failure center can be initiated through the 5 stages of the adoption process of the diffusion of innovations theory by Rogers. In the knowledge phase, the physician and mid-level providers will be exposed to telehealth or e-health. In this phase, however, the providers may not yet be inspired to find out more information regarding the innovation. It may seem to be a possibility, but not necessarily something the providers might consider an actual probable solution. In the second phase, persuasion, the providers will become more interested in the innovation and may seek information related to telehealth. This is the phase in which education, as well as outcomes and statistics, will be offered to the providers. In the third phase, the decision stage, the providers will weigh the advantages and disadvantages of using telehealth or e-health in the heart failure center. One of the main drivers for telehealth is its potential to lead to savings from the reduction of unnecessary hospital admissions. Key challenges for the innovation include poor access to technology and organizational infrastructure that fails to support the innovation, the issue of replacing face-to-face contact with remote technology support, and affordability. In the implementation phase, the individual employs the innovation to a varying degree depending on the situation. During this stage, the usefulness of the innovation is also determined. The individual may also desire to find more information regarding the innovation. The final stage, confirmation, is when the providers can finalize their decision to hopefully continue with the incorporation of telehealth or e-health. A decision may be made to start to use the innovation to its fullest